Good morning, everyone. My name is Junaid Sayani. I'm a post-ECT diabetic foot fellow working at Basildon Hospital with Mr. Thurrock. I'm presenting our results on DEBRICHEM in diabetic foot. So just to start off with explaining kind of the problem at the moment, which is that about 80–90% of chronic wounds are infected with a biofilm layer that inhibits healing. This is composed of both planktonic bacteria as well as bacteria attached to the cell surface. This biofilm is quite difficult to remove. It can't be cleared by host defenses as there's no blood supply to the wound. So no amount of antibiotics will ever clear it. So at the moment, we use mechanical debridement on the whole, which works to some degree, but is quite time consuming and there is quite a significant recurrence. It's quite hard to get into the corners. It can be quite painful because it takes quite a long time. For this reason, it can be quite inconsistent, and sometimes you get quite significant bleeding. So a lot of the patients with hypergranulation tissue, they do tend to bleed quite a bit, and this can obviously be problematic. The biofilm is about 90% water. DEBRICHEM itself, when it's applied, it produces an energy level of about 1,500 kilojoules per mole. This has an extreme drying effect and removes the biofilm from infected areas. And as you can see from the diagram, the water around the bacteria causes desiccation of the bacteria itself as well. The good thing is it doesn't affect healthy skin. DEBRICHEM itself is a strong acid, but the way that with the method it works in, because normal skin has low water content, it doesn't actually affect normal skin. It's very good for getting into the crevices. As it is a liquid, I found it's very useful to get underneath. Sometimes the granulation tissue can be going over the healthy skin, and it's useful to apply it both on top of the granulation tissue as well as underneath inside the crevices without any concern that the skin, healthy skin under it, will get damaged. So first case study, as I said, I work mainly with diabetics, so my presentations are all regarding diabetic patients. As a 33-year-old insulin-dependent diabetic, she was walking barefoot on holiday and burnt her foot walking barefoot. She initially had an emergency debridement in theatre in November 2023, and then we tried to use an artificial skin graft to get her to heal. Unfortunately, infection was problematic, and despite repeated efforts at debriding, it was quite difficult to treat her. So this is 15th January when we applied the DEBRICHEM. So you can see on the left, there is the pre-application and then right post-application. Once it's applied, it causes browning of the area. And then over the subsequent weeks, it did start to heal. Now, the areas that didn't heal, it was, I think, more an issue with application. This is serious from the first time we used it. And one thing we found is that as it is liquid, it tends to run down with gravity. So when you're applying it, you have to make sure that the tissue is flat, almost like a Petri dish. So when you apply it, make sure that gravity is not going to be working against you. Subsequently, she has healed significantly. Recently, we applied a split skin graft to heal the rest of it. Next patient, a 59-year-old type 2 diabetic. He had a forefoot amputation done 8 months ago with very slow healing wound. I tried to improve this by performing a 2-incision Hoke technique to lengthen the Achilles tendon, reduce the pressure on the forefoot. Once again, this wasn't healing, so applied DEBRICHEM with finally a heel shift at the end. So once again, pre-post application, you can see the desiccant effect. And this is healing by 1st February, so that's within 2 weeks. The non-pressure air part of it is healed. And this is the most recent one on 28th March where it's healed completely. So obviously, as well as applying the DEBRICHEM, you have to make sure that there isn't a pressure effect in it. There is good vascular supply. DEBRICHEM works very well to clear the bacteria, but if there are other causes to the ulcer, then those need addressing at the same time. So it's a good armamentarium in the fight against ulcers. And then we've got a 65-year-old type 2 diabetic who once again had an emergency debridement of the right foot after an infection and subsequently ended up with severe hypergranulation tissue. So you can see, as I was describing earlier on, the granulation tissue is going over the healthy skin margins. Now, cutting into this caused quite significant bleeding. There was profuse bleeding if you try to cut into this, which is not always ideal in the outpatient setting. So we applied DEBRICHEM to it. Within a week, we had significant improvement in shrinkage of the hypergranulation tissue. It carried on decreasing in size. Once again, with this, I found that gravity once again worked against the liquid. So the inferior part of the wound had healed better than the superior part. So I did end up having to resect some of the granulation tissue. And then I used silver nitrate to complement it. As we progress, he now has a very small wound left over. So to summarize, I think DEBRICHEM is a very good tool as long as all the other causes of ulceration can be addressed. It needs to be applied correctly. I think that's key to the product. If it works well as long as it's used correctly, with very rapid healing. Actually, I've got, as you can see, some of these results are within a week for ulcers that have been around for 8 months. So it's very, very good at helping discharge patients from clinic. And as said, important to exclude other causes.